This is a short videotape to look at the relationship between obstetrics and obstetrics on the one hand and gynecology on the other. There's always been a very close relationship between the two situations, and never has it been more important to get on top of it to prevent a lot of preventable gynecological morbidity to the mother. This work's been done largely in Shanghai Jiaotong University in the Peace Hospital here, 16,000 deliveries. This is the main ward block. The labour ward's on level 4. This is the outpatient department and the service unit over here. And there's nothing new about these ideas. They were first set out by Professor Sir Dugald Baird in the first edition of his textbook in 1923. The vast majority of gynecological problems arise from infections or injuries during a first labour. And the primary source of them is injuries to these nerves. And these don't feature in either obstetric or midwifery textbooks because we lost them in the post-war years. This is the sacrum, this is the pubis, uterus, cervix, vagina, rectum, bladder, and all these autonomic nerves coursing down to towards the junction of the uterus and the vagina, where they're very vulnerable in a first labor. The reason that we lost them was because we started immersing cadavers for undergraduate education in formalin, and the formalin destroys the autonomic nerves. So the whole of the nerve plexus is illustrated by numbers 8, 32, and 33. The nerves run through the uterosacral ligaments, which we see at laparoscopy very conveniently. And if these get injured, then you can guarantee that the nerves within them become injured. And that's what is the primary source of problems in subsequent years. Here's in the bottom two panels, 2 injuries during labor. Here, the woman's almost ruptured at the posterior wall of her uterus. She's lost her left uterosacral ligament, and you can almost see through the right one. On this side, the left uterosacral ligament has been replaced entirely by veins. This woman simply had a forceps delivery. Here you had a woman who was administered misoprostol. This was for evacuation of the uterus, but she went on to have 4 consecutive ectopic pregnancies because of the injuries to the nerves sustained in the uterosacral ligaments, which supply her both her uterus and fallopian tubes. And finally, you have these very large, very thickened uterosacral ligaments. Again, the nerves are injured. This one is non-iatrogenic. This one is caused by straining during defecation. When you look in the uterus, and you have to look specifically in the isthmus, this is what you see. In the normal uterus, this is normal endometrium, normal myometrium, and this is an important endometrial myometrial nerve plexus. But in all these difficult situations that we've described, you see these abnormal injured nerves. And in this particular one, which you get from prolonged maternal voluntary efforts in the second stage of labor or straining on the toilet, you get this longitudinal injury to the nerves, which produces this thickening of the denervated arteriolar wall and narrowing of the lumen. And it's the combined neurovascular injury that creates a lot of problems for the woman from a gynecological standpoint. We looked at this in the 2,240 nulliparous women in the Avon longitudinal study of pregnancy and childbirth in Bristol, 1992. We found that any of these variables doubled the risk of severe gynecological symptoms at 47 months postpartum. And that by severe gynecological symptoms, we meant severe gynecological pain, chronic pelvic pain, menstrual problems, irritative bladder and bowel symptoms. We would have preferred a data set at 10 years postpartum, because I think this severely understates the problem, because most women present when their first baby is 7 or 8. Often they've had an intervening second child. And it's only at about 5 to 10 years that you'd have a clear idea of the amount of intrapartum injury that causes severe gynecological problems subsequently. Aside from those, I found in the clinic that these 3 problems are very severe in terms of subsequent gynecological problems. This is a normal nulliparous pelvis here. This one shows that the muscle adults, and inside them the nerves have been completely avulsed following either premature or prolonged maternal voluntary efforts in the second stage of labor, and or excessive uterine activity associated with the administration of different uterotonic drugs such as misoprostol, oxytocin, and or prostaglandins. We know it's important because most gynecological syndromes have this sort of appearance with the injured nerves surrounding a thickened arteriole, but we've known about the similar pattern in the obstetric, in the pregnant uterus since 1945, when Arthur Hartig described narrowed uterine arterioles in the placental bed, but nobody has discussed this empty layer of hyalinized cells, which we believe reflects this injury, these injured uterine nerves. So that injuries to the uterine nerves are the consequence of most obstetric and gynecological syndromes. It's for this reason that you need to maintain the integrity of a woman's nerve supply as best you can. So this is the conclusion that we've come to. Simply, in this exercise in the Allspac study with proband number 2, lifelong painful gynecological symptoms that result from suboptimal management of intrapartum during first labors. Number 1 and number 3, I think we're aware of from different strands of evidence, and it's vital that we put in place neuroprotective intrapartum procedures during nulliparous labors to try and prevent a great deal of this entirely preventable morbidity. Obstetricians need to avoid inductions of labor and forceps deliveries. There's absolutely no need for forceps. Most of the time you can do a much better job with a disposable ventouse, and most of it is in the coaching of the woman to push appropriately. Secondly, there are very serious consequences for induction of labor, and it's vital that you avoid induction of nulliparous labor wherever possible. As far as the midwives are concerned, clearly you need to restrain yourselves in terms of the length of the first and second stages of labor. You certainly need to get the management of the second stage absolutely precise, because as soon as a woman's pushing for 2 hours, you can guarantee gynecological consequences, which are going to result in lifelong neuropathic pain. Professor Sir Dugald Baird told us all about this in 1923. There's nothing new. We've had this for a century at least, but it's time we got on top of it because it's causing an enormous amount of morbidity for women in this country. And it's vital that the labor wards are better organized with a proper framework of management that prevents neuropathic injury. So something novel, something new, something to reflect on before you next go to the labor ward. And thank you very much for listening. We look forward to seeing you on the next video.